Hello everyone, I'm Professor Alexandra Johnstone and I studied at the University of Aberdeen a master's degree and then finished my PhD away back in 2001. So my role now is actually still working within the University of Aberdeen at the Rowett Institute, where I hold a personal chair, which means I'm a professor in human nutrition.
I'm Murdoch Shirreffs. I studied medicine at Aberdeen, qualified in 1970. After that I entered the first year of the GP training course in Aberdeen and then took a MRC GP. I then went into practice at Bucksburn and Dice, the Gilbert Road practice, and I was there for 41 years. During that time I got further qualifications. I became a registered hypnotherapist, and I also studied homeopathy and became a specialist in homeopathy. Also in earlier years I took a diploma in obstetrics, which I never used in practice.
Hi everyone, I'm Dr. Obinna Ubah. I studied at the University of Aberdeen. I did an MSc in clinical pharmacology and a PhD in molecular biology. I currently work in a biotech company which we spun out from the University of Aberdeen in 2016 called Elasmogen Limited, and in the company I'm the program lead in drug discovery for autoimmune inflammation diseases.
Hi everyone, I'm Professor Rona Patey. I graduated from the University of Aberdeen in 1982 with a medical degree and worked initially in and around Glasgow, and I did training in anaesthesia and for a time in emergency medicine, but my clinical practice as a consultant was in anaesthesia. So after a short period of time working in the States, I took up my consultant job here in Aberdeen as a consultant in Eastus 1992. I became involved in teaching, both postgraduate and then undergraduate, at a time that there was a big change in medical education in the UK with the production of the GMC's Tomorrow's Doctors. And over the course of the last 30 years, I've done more and more teaching, and now I just stopped clinical practice last year at the end of the summer, and I work predominantly now on the university side as the director of the Institute for Education in the School of Medicine, Medical Sciences and Nutrition. Well, I couldn't, for sure. It was never in my mind, first of all, that I would be an anaesthetist. I thought I was going to be a pathologist. Through the initial posts I had as an SHO and as a PRHO, became interested in emergency medicine, and through going into emergency medicine, they gave us an attachment to anaesthetics early on at the beginning so that we could have resuscitation skills, and I loved it, and practically I could do it, and it was so nice doing something that you felt you had a little bit of aptitude for. That's what led me into anaesthetics, and it wasn't really until I became a consultant or was moving towards becoming a consultant and I worked in the States for a year doing a trauma fellowship, and I did an ATLS course, advanced trauma life support course, that was just being introduced to the UK at that time. And was nominated for instructor status to start instructing on that, and I think that was the catalyst that then led to me becoming more and more involved in education. So I think my whole career relates to serendipity and chance.
Yeah, that sounds like my encounter as well. So I originally trained as a pharmacist, and all my life I've just thought I was just going to be a pharmacist, work in the hospital as a clinical pharmacist. until I encountered University of Aberdeen. So when I moved here in 2010, did an MSc in clinical pharmacology, okay? I then realized that there is actually a part of pharmacology called molecular pharmacology, and I became more interested in that, and that was how I did a PhD in molecular biology. And then during the PhD, my PhD supervisors were more commercially driven. You know, they are scientists, but they were commercially driven scientists. And I found that fascinating because I never really knew that, you know, you could actually commercialize science under the roofs of a university, right? So I decided to go on a course called the Business of Science. That was a funded program at the University of Bologna in Italy. So it was a month EU-funded program, and I came back, and it seems to just changed my perspective about research and the whole idea of research translation. And I moved towards, you know, more translational type of research. So in the sense, research that I could commercialize. And at the end of my PhD, we just naturally just spun out a biotech company. And, you know, it wasn't something I saw. I didn't foresee that when I, you know, when I came to the UK, but that's how I found myself doing what I do today, which is quite fascinating.
Yeah. I think I was probably reasonably sure what I would do. I've always liked doing a whole range of things. So it was either a choice of GP or perhaps going into accident and emergency medicine, because in those days as students, we weren't so safeguarded, so we were able to turn up at casualty department down a Roman Hill and just pitch in, and you saw a wide range of things there. But I think I always fancied GP. The only problem at that time was that there was a shortage of posts, so well, it'd be nice to stay in Aberdeen. You thought, well, maybe I'll have to move away. But I luckily did find a post, and I've been there ever since.
So I think I can reflect that I didn't know what my career was going to look like. So I also, when I did my MSc, similar to you, I really enjoyed doing research, my research project. I was just amazed that you could come up with a question and collect data and answer that question, but then I also had another 100 questions, so I loved it. So in a sense, as soon as I finished my MSc, I was lucky enough to get a post at the Rowett, and you know, I knew I wanted to do my PhD because I knew that I'd found something that, you know, I could really love as a career. But I think that at that point, I wouldn't have been able to predict that I was going to be a professor. So in STEM subjects, in science, technology, engineering, and maths, there are very few women actually that make professor. And at the Rowett Institute, we unveiled a painting last year of the first 5 female professors. So it was a very male-orientated environment, but now it's much more diverse, and we've got equality, you know, across the genders. So I think I feel very lucky to be able to pursue a career that I'm passionate about. So.
Well, in some ways it means almost everything, as it does to the vast majority of the British public. It's when you compare the traumas, financial and otherwise, of people who in other parts of the world, when they fall sick, it's lovely to have everything relatively cheap.
Yeah, I mean, like you, I've got a strong emotional feeling about the NHS. It's given me my career, and it's been there. I worked in the States in a trauma centre, as I said, just at the end of my training in anaesthesia before taking up my consultant post. And I've been back to visit the States from an education perspective, reviewing programmes in the States and clinical placements in the States. And I think what I could see is the patients are the patients wherever you go, but the system of care is so complex and so fragmented in some other countries. And the access to care can be phenomenal if you've got the resource to get it. But for the vast majority of the population, I think in pretty well every country in the world, they don't have the resource to have that kind of access. And I think particularly for patients in the UK who have chronic conditions, who have asthma, who have chronic neurological conditions, who, a myriad of things. The fact that your whole family finances don't go on the line because of that. That's not to say I don't think there aren't things could be infinitely better with the NHS, but for me, it's something that the UK still should invest in and still should be phenomenally proud in, because the alternatives that I've seen for the majority of the population are not great.
And I think one of the benefits is the record system that
Yes.
Instead of having to tell your tale to every new doctor you go to, it's all the GP records gets transferred from one practice to another if you move away, and there's more and more linkage into the hospital.
And I guess the rollout of the recent COVID vaccination scheme was a really good example about how the country knew who people are. It's not to say that other countries weren't able to do that, but the NHS system certainly was very helpful in the speed of rollout.
For me, it's not just, I think, my background actually. So I come from Nigeria, okay? So the healthcare system is nowhere close to what we have in the UK here. So coming here and experiencing the NHS and what it could actually offer, and trying to extrapolate that to a low-income country, seeing how that could make a huge difference to the lives of people in poorer countries, and you begin to appreciate what the NHS means here in the country, right? So probably just 6 weeks ago, the NHS did change the lives of my family, like kind of, to an extent, did save a member of my family from an imminent death, I think. So my wife does work for the NHS, and clearly, I mean, the satisfaction, the job satisfaction that she exudes kind of tells it all. What, they go into work, they feel, they deliver their services to the people, and they feel so very satisfied at the end of the day. So those kind of things, I think they are legacies that should continue, right? And I have so much respect, for the NHS. And of course, I'm not in a position to say what should get better, right? Because to me, it's good compared to where I'm coming from. But I understand, speaking to you guys, there is a lot that needs to improve in the NHS. But yeah, that's my view. So
I think we're quite lucky that University of Aberdeen is on the site with NHS Grampian. And for me as a scientist, and I have an honorary role within NHS as a clinical scientist, it means that we can integrate and translate our research straight into medicine. So, working within the medical school, that just is really important to me, that my research is translated, so that for me it's important that my research makes a difference, and it can make a difference in different ways. Of course, it could be policy, it could be working with food industry, but for me, working with patients and clinicians so that we've got evidence-based research is something that, is one of my passions.
Yeah, I guess the same thing for, professionally, yes. It's a bit tricky, industry, NHS type of collaboration with regards to translation and, creating the impact from our research, right? But it is something that we value so much, that if that kind of collaboration or interaction could be sustained, then there is so much benefit, not just for me as a researcher coming from an industry, but also for UK PLCs, being able to quickly translate our research, and create impacts in UK's ecosystem. So I think the NHS is positioned to deliver all of that for those of us in the industry as well, in life science industry, I would say, yeah.
Well, I was employed, and in fact I still am employed by the NHS, and I'm seconded to the university. And I think that's, Alex, you were talking about this site. I think that's one of the special things that I have really benefited from on this site. So it's given me my salary for my virtually my whole working life, apart from a few jobs picking raspberries and being a postie as a student and these sorts of things. But I mean, my primary role now is with regards to education, and it's not only healthcare education, it's medical sciences education, but we're here on this site, and we have a very large population of students studying healthcare programs, medicine, dentistry, physician associates, and then postgraduate students who are NHS staff who are doing postgraduate qualifications, MScs in public health or medical imaging or advanced clinical practice. So everything that I do is linked to the NHS and to the work of the NHS one way or another.
Well, for my working life, I, as a GP, was actually self-employed, because GPs weren't actually part of the NHS. They contracted their services to it, which was something, when it all started, was felt to be a good thing. Now, the positive thing about that was you weren't sort of bound by governmental rules. You could run your own practice in the way you wanted, which was fine if it was good, but then there were a lot of practices perhaps didn't run very well, and there was little sanctions to pull them up. As the years have gone on, as practices have got bigger and bigger and there's more admin, I think the younger doctors are finding the business of being a business manager as well as a doctor is something that they don't really want to do, so that you're seeing more and more practices, merging or being taken over by sort of companies to run the business side of it, and I think that's probably the way to go. So
I can reflect that my research on diet and health, I hope, gives evidence on how to keep people healthy, so it has a sort of preventative role, but I can also reflect that I am also involved in teaching, so in terms of research students, medical students, or undergraduates and postgraduates, giving them skills so that can continue in the future in terms of research within the medical school.
Yeah. So basically, in my specialty, as I said, I develop drugs to treat chronic inflammation. If you look in the UK, there is over 1 million people who are suffering from rheumatoid arthritis and IBD, for sure. So in the NHS, of course, there are lots of medications that are, available to treat most of these patients, but you still have a significant percentage of these patients having unmet clinical need, right? So these patients are not achieving disease control or remission. They are not staying in remission just because either the drugs became unsafe for them or they became tolerant to the therapy. So one of the things I'm doing with regards to my research is to develop not just safer medicines, but medicines that have better efficacy than the existing therapy. So what I intend to achieve with this is to provide the NHS, the doctors, a better, better option of medication, alternative medicines to use for patients, to get more patients into disease control and remission, and at the same time keeping the patient safe with the new medicines they are taking. So that's how my work ties into the NHS, yeah.
First of all, the site that we're on in Aberdeen is a very special site at Forester Hill, and some say that it was influential in the design and the thinking of the NHS, but on this site we've got all the healthcare education that's delivered by the University of Aberdeen, or the overwhelming majority of it. And we've got several of the hospitals, and the majority of the hospitals for NHS Grampian, and one of the general practices, the Forester Hill Health Centre. So the students who are learning healthcare are learning on the site that healthcare is being delivered. They're learning alongside the continuing professional development of every healthcare professional that's here on this site, and there are thousands of healthcare professionals on this site. So they're you know, for the students, it becomes part of their DNA from the minute they start learning at the university by this arrangement of bringing healthcare education and research and the delivery of healthcare all together on one site. So it's really important, and I think that it's not just about medicine. Our medical students are our largest number of healthcare students. We've got smaller numbers of dental students, physician associate students, and those doing postgraduate programs. But those students are all working with the multi-professional teams within the NHS. So it's, you know, it's a peril for these people who are coming to learn at this university. I can't imagine how you could think of a better arrangement to design. So the university works very closely with NHS colleagues. Our students are on clinical placement. In the NHS, of course, we have people going back and forth, arranging those placements. We have clinicians who are coming and they're delivering teaching to the students whilst they're in sort of on the campus in the teaching facilities. And we're here in a simulation facility that is jointly managed, jointly run for students at the university and for staff in the NHS. You know, we're so intertwined. It's amazing. But I'm sure you guys can talk much more from the research perspective.
Yeah, I guess that's what we call the triple helix on this campus. So very, very beautiful, because again, in the bigger picture, it then begins to foster collaborative tendencies in the younger students, where they begin to interact with people from different disciplines, possibly different sectors, because even in my facility, we do have clinicians coming to do research, right? Research, PhD, and they get to learn how business development is done. These are clinicians, right? So they begin to understand that there is this ability to do cross-sector, cross-disciplinary collaboration and partnership, even as clinicians. So that's amazing to have that triple helix in place, yeah.
Not to forget the patients as well. Patients have such an important role, particularly from a research perspective, in the co-production of the research. So it kind of works two ways, that I can use my expertise and knowledge in the teaching, but also clinicians with their experience and expertise want to improve treatment for their patients. That's often when they would come to me and say, well, I want to do a dietary assessment, and how can I achieve that? And it's very current now that we include patients even at the design of the grant stage all the way through as patient advocates. So that's great.
And that's the same in the
Yes.
teaching side as well, Alex. Not to give any surprises away, but every year when if I do the welcome address at the medical student graduation, I always talk about the gift that patients give, and their extraordinary willingness to allow not just students, but when we were trainees, to learn from them, and to continue to learn all the way through their lives, and our careers and our lives. It's really an amazing relationship.
Well, more than a little bit. I can do so from a GP perspective. general practice was going down the tubes in Britain in the 60s. A lot of people were emigrating, so they could get better money. And at that time, money was then made available to build modern premises. And I think that made a big difference. So when I came into practice, we were still operating in the old style of paper notes, what were called the Lloyd George things that were started in 1911, where you had an A5 little packet into which bits of paper and letters were stuffed. And probably one of the things that helped most was that the Scottish government was particularly generous compared to the English government, where it gave us all money where we could buy A4 folders, so that everything was actually flat, and you could read the letters more readily rather than pulling out great streams of paper, which was all mixed up. Now, records are the key to good care, so one was then able to go through all the stuff and make summaries, so you had a potted history of the patient in front of you. So that was one thing that helped. Money was also, we also sort of got more support staff. There was practice managers and then receptionists. It wasn't the doctor's wife answering the phone all the time. Well, it was for a little while until we got mobile phones. But that was very helpful, so that one was able to work in better things and much more readily do it. Also, there were a lot more women come into practice then. There was much more, it used to be male orientated, so that gave a much greater sort of spread of choice for patients as well. I think too, my generation were much more, I suppose, confident in what they can do. I mean, we had an excellent education at Aberdeen. In fact, I seem to remember there was the Time magazine ranked Aberdeen as the third best medical school in the world in the late 60s. So with the GP training course, you'd had a much more experience when you came into practice. It used to be often in the old days, you did your 1 year pre-registration and then you could go into practice. So we were much better skilled, much more confident. So I think what developed over the years in Aberdeen in this area was that there were a lot of contemporaries who we used to liaise with each other, discuss developments of our practice. And we took on more and more stuff that used to go to outpatient departments for follow-ups. Just like people had heart attacks, asthma, and so on. And it's not that difficult to do, but you have to do it consistently, and good records helps that. So I suppose in later years, diabetes care then came into practice. And so there was a wide range of things, and the nurses became much more qualified to do these things too. Computers, of course, came along, which were just a tremendous change. For a start, it produced prescriptions that chemists could actually read. But it was, as well as having great records, they had fantastic search facilities, so that if you wanted to, for example, check up on people, you could type in, say, I want males over 60 who had diabetes and had a heart attack and who were on a particular drug, and it would just give you these. So that helped the care as well. This out-of-hours service, of course, it used to be we did night visits at home, which were interesting. In some ways, it was people were almost in this area were reluctant actually to get you out of bed, and they'd have a chest pain at 3 o'clock in the morning and say, I don't want to trouble the doctor. But unfortunately, as time went on, people generally were phoning up for more and more minor things that could have waited, and I think that was when we got into what was called the GDoc service here, which was much safer for patients. And in fact, it was great. You saw your colleagues, and it was really good fun too. I think as time has gone on, in practice, personally, I found that although there's a lot of things modern medicine can do, there's a lot of things that happen to human beings that don't fit into nice slots. And as I mentioned earlier, I started doing hypnotherapy, which was very useful for a lot of psychological things. But there's not only myself, but there's another 6 or 7 GPs who also got interested in homeopathy. And I actually went on to become a specialist in that, and there was actually a service funded by the NHS in Grampian for quite a few years where people could get referred for homeopathy. And while there is this thing called TEETH, the acronym, try everything else, try homeopathy, there were quite a lot of people who seemed to get significant benefit, and that was very nice, because it's frustrating when you get people with problems that say, well, you've tried everything and they're not getting any better. And there's, of course, your job in medicine, I mean, that's helping it, and we do much more for people, but there's a lot of subtle things to do there. So there we've seen lots of changes, but in some ways what we took on for ourselves has been a bit of a double-edged sword, because it's meant that people have, doctors have had more and more complex things to deal with in their practice. And while there's an answer to getting nurses to deal with the more straightforward things like urinary tract infections and sore throats, the problem is in a surgery session, if you got one of these coming in, there was a little bit of relief between more difficult things. But now I think all the GPs are getting complex things all the time, and this is maybe partly the reason why so many people are not coming into practice. So I had a lovely life in general practice, but I'm not sure I would want to carry on as it is just now.
I mean, so much has changed. Of course, at the heart of it, it's still a clinician and a patient, and that doesn't change, does it? That's always there. But I mean, just to pull out a few things that I've seen change. First of all, you referred earlier, Murdoch, as medical students, we did locums. We actually practiced and got paid, not an awful lot, but we did get paid to do locums, and my goodness, that focused the mind on your learning. But you could never advocate that as being a safe approach, but it was a very powerful learning experience. As an anaesthetist, one of the things that I really can reflect on and see is the patients who come for major surgery with concomitant comorbidities, quite severe, serious comorbidities, that previously would not have been offered surgery because their condition would have not been so well managed as it is. And that's both due to systems of management, but also to improvement and developments in therapy. So when I think about the introduction of ACE inhibitors and what that meant then to the kinds of patients who could come forwards for major surgery that might significantly improve the quality or extend their life. It's just unbelievable, really, compared to when I was a trainee in anaesthetics and where I am now. And the technology now, of course, with virtual consultations, it was during the COVID pandemic, one of the things that I did, actually with a telephone, not with face-to-face, but doing the pre-assessment for patients who were going to come in for aortic surgery, which is just massive surgery, really major surgery. The patients used to have to fly. Some of them were in Aberdeen, of course, but in preparation for that, they'd come to the pre-assessment clinic and they would fly from Orkney or from Shetland or from wherever they were. And we did it over the phone in half an hour, and it was very acceptable to them, and it was very acceptable to me in terms of being able to assess them whilst accompanied by the online records. The only downside, I would say, is the number of passwords that one has to now deal with, which is a real challenge, and the volume of work is extraordinary. And I think your point about consistently dealing only with really complex cases, I don't think that gets thought about enough when we think about the stress for individuals. And the final thing I would say that I think is really important is been, since the millennium, really the understanding about error in healthcare, and the realization that there is science from other areas, human factor science, understanding about systems of care. I think that's transformational, and I think we're still on our journey to really getting the best benefit for the community on that.
It is interesting about how pressure is perceived, because in times past, doctors in hospital used to work long hours, 90, 100 hours a week, and then the European regulations came in to cut it down to 48. So I think how it affects people psychologically to say, well, I'm not prepared to do work that long. It perhaps means that if the things are getting pressurised, they have a lower threshold of feeling, oh, I'm getting stressed. Whereas some of my generation, and perhaps Rona's, because you were so used to working these long hours, it didn't seem quite such a problem. Because it did have the downside, a lot of people became very stressed and unwell with it. So it's just a balance. But I do just wonder whether, it's a generalisation, maybe more recent generations aren't quite used to put in the hours quite so readily as...
Although I still think they work,
yeah.
I still think they're working significant hours, but it's definitely changed enormously, yeah. I think, I'm not sure where it will be next year. I mean, that's a bit of a flippant statement, but healthcare is changing so rapidly right now. We're trying to predict the clinical placements for our students 5 years ahead, and what things will be important for the role that, let's say, a medical student when they graduate will have. But we don't actually know what the shape of the NHS will be at that time. And so we don't know what the shape of their job will be, and we don't know how some of the healthcare pathways will be structured. So that makes it and what the healthcare team is, so that makes planning how you meet the right learning outcomes so they have the right knowledge and skills. We're reviewing it all the time. We're constantly reviewing it because there are constant changes in the NHS, and that's not maybe constant changes just in the NHS, it's constant changes in healthcare and what we understand, to a lot of it due to the research that you guys are doing on what the best way forward is, or what the right system of care, the most efficacious system of care, and also what patients want. That's changing too, I think.
Because there's almost an existentialist problem that you folk are doing such wonderful work that if we can virtually cure cancers and cure dementia, we're going to end up with a population full of people who are 100 or more, and you just wonder whether time is going to come, because who's going to look after them? Are we going to have to consider having virtually assisted dying because nobody's going to be able to look after them? Now that perhaps is a doomsday scenario, but I can certainly see with artificial intelligence you could well get avatars and robots that are so clued into brains. In fact, you could probably pick up brain waves. I believe they can do that even already just now. There's somebody who was able to walk. His brain, after being paralysed, because his brain could tell could send signals through a computer to his nerves. But it may well be that there's more and more going to be artificial things that do most of the caring and can do it in an empathetic and accurate way. Interesting times lie ahead, and I hope that I have another 20 years to see some of them.
I mean, just talking about, the power of data, as you say, so power of data, being able to, exploit the data that we've been collecting about patients, their drug use, their past medication history and all of that, and trying to stratify patients for the right therapy at the right time, picking up, doing, effective diagnosis, early on, and stratifying these patients into groups of, into different groups where they will get the best benefit from a therapy is something that is now taking off actively in the NHS. And you see most clinicians I talk to are moving away from this generalized use of maybe an anti-TNF therapy for all patients that have rheumatoid arthritis to a situation where, okay, actually we need to do omics to understand the biomarkers, see which patients will respond better to a therapy. And I think that would actually also improve the quality of patient life. But as you said, research is very dynamic. This is just us looking at what is currently happening right now. But this all could change, with, new informations coming in. But yeah, in my field, we are now talking about, as you said, AI, machine learning, using that to design the next generation of therapies, right? So it's exciting to see what all of this put together would deliver for the patients, and also for the how the NHS will exploit all these new technologies and advancements in caring for patients. That's quite an interesting outlook for me.
So I also have a blue skies sort of scenario that we would hope that clinicians and researchers will be able to come together to expand lifespan, but as a health span, so that we can all live longer, but for a better period of time, so that we can treat diseases earlier. Like, you could imagine a scenario that you get a finger prick at birth, but not only for the standard care that is given now, but then you can look at genomics, you can look at gene profiles and predict what the risk factors are, so that you can have a programme of intervention or lifestyle medicine that will promote good health. So, and yes, I do think that technology is going to change, that the way that we treat diseases in terms of joint replacement, whether we can target joints early on with specialised treatments, whether we can cure Alzheimer's disease, cure some cancers. I think, it's such an exciting time to be involved in research, but with a purely sort of positive spin in terms of how we can use all these skills and resources in a positive way to live longer.
Because the ideal thing would be to have all your marbles still, and get to about 100, because I remember over a career, I had 2 or 3 old ladies who eventually just faded away, but you had to try and find a diagnosis to put on their death certificate, and they just died. It was, you used to find a lot of people that were like a bunch of flowers. You'd put them in water and they'd be there for 2 weeks, and they were absolutely fine, and then just over a day or so they would just wilt and fade away. And I think it's this apoptosis, isn't it, cell death. They just run their course and they just faded away and slipped away peacefully. So maybe that's what we wish for.
But that having great quality right up until
right,
that
yes,
moment.
yes.
It's a good vision, isn't it?
Yeah.
Mm-hmm.